Good afternoon, everyone, and we'd like to welcome you again to the 10th Language of Love Telethon for Stroke and Aphasia Awareness. And we'd like to just thank everyone that has been with us all of this time. And we're welcoming our friend for many years, Dr. Richard Libman. He is the Vice Chair of Neurology, Chief Vascular Neurology, and Professor of Neurology, the Zucker School of Medicine at Hofstra, Northwell. And good afternoon again. It's an interesting topic that you had brought up, the impact of Alzheimer's disease treatment on the safety of stroke treatments. So I'm going to throw it to you and tell us what's going on.
Well, thank you very much, Ginny, and it is a pleasure to be back. And so now I am going to talk about this kind of emerging topic in stroke, and it's one of the most interesting topics in stroke because it surpasses the field of stroke itself and kind of extends into the field of dementia and specifically Alzheimer's disease, which is the most common cause of dementia worldwide. Just as an aside, Alzheimer's disease, most common cause of dementia, vascular dementia, that is due to stroke, the second most common cause of dementia worldwide. So Alzheimer's the most common, stroke the second most common. When you put them together, they account for a huge number of cases of dementia, meaning cognitive decline or cognitive deterioration, with many different causes, but Alzheimer's being the most common. Why has this suddenly become so relevant for us as stroke clinicians? The reason is that many people will know, because it's been in the newspapers, it's been in the press, that over the last just couple of years, there are now FDA approved new treatments for Alzheimer's disease. And these treatments are the first treatments ever to be shown to actually affect the course of the disease, meaning to slow down the worsening that comes along with Alzheimer's disease, because it is somewhat relentless, let's face it. We have had other medications on the market for Alzheimer's disease that have a slight effect, but they are purely what's called symptomatic, meaning the medications that are available or have been available up until now treat the symptoms, may improve memory a tiny bit, and some people notice a little bit of improvement, some people don't, but they don't have any actual effect on the deterioration that is caused by Alzheimer's disease. In the last 2 years or so, at least 2 new drugs have been FDA approved. They are kind of drugs that have effects which are analogous, similar to the immune system, and antibodies that help you fight disease and that help clear germs from your body. In this case, in Alzheimer's disease, there is an abnormal substance that accumulates in the brain, and it looks as if that abnormal substance damages the brain and results in dementia. And this substance may be familiar to some people because, again, sometimes they'll use the word, and it's called amyloid. And amyloid is a kind of protein. It's basically a protein that is not shaped correctly. And when that incorrectly shaped protein builds up in the brain, that is one of the hallmarks of Alzheimer's disease, and brain cells become destroyed. And that's why people lose their ability to remember things, to process thoughts, to plan, to do all kinds of things that we associate with our, higher mental faculties. So I'm digressing a little bit away from stroke into dementia, but I thought it is very, very important to sort of set the stage, because so many people, not only nationally, but worldwide, are affected by Alzheimer's disease. It is a major problem for society as a whole, all over the world, interfering with life, quality of life, productivity, because Not everybody is 98 years old when they get Alzheimer's disease. You know, people can be affected by it earlier, not just in their 80s, in their 70s, sometimes in their 60s, sometimes even earlier. So Alzheimer's disease is a major problem. The fact that recently we have some medications which are these kind of immune cells that can remove this toxic protein, remove this toxic amyloid from the brain, and seems to result in slowing down of the disease, is nothing short of a miracle, because it's what everybody was hoping. It's kind of analogous to the discovery of TPA for stroke. 25 now, almost 30 years ago, we had nothing. We had nothing. There was heparin and this and that and Coumadin. People are familiar with that. Everybody knows that's basically going to do nothing most of the time early on during a stroke, you know, when you want to help people recover right from the get-go. So we had nothing. And TPA was a breakthrough, and TPA was revolutionary, this clot-busting drug. These new medications for Alzheimer's, while they may not be miracle cures, they're not sort of reversing the effects of Alzheimer's, and people aren't suddenly, you know, bouncing back completely, but it is slowing down the disease, and that's pretty much been proven in clinical trials. So in that sense, it's miraculous. And no doubt, now that we've made like the first dent in the armor, that first chink in the armor of Alzheimer's disease, I'm sure more medications are going to follow, you know, in the near future, because this is the proof of the principle of the concept that Alzheimer's is not completely untreatable. Okay, now having said all that, why are stroke neurologists interested in this? Well, we are very interested. Why? It turns out these treatments, like so many treatments in medicine, while they have a beneficial effect, also have side effects. And one of the main side effects of these new treatments for Alzheimer's disease is that they can cause bleeding in the brain. Lo and behold. Okay, in an Alzheimer's patient, someone with Alzheimer's being treated with these new Alzheimer's drugs, there's a very small chance that they will get bleeding in the brain. It's like 1% or less or something like that. It's not zero, but 99% of people are not getting bleeding in the brain, and they are getting some benefit from the drug. However, because this is a drug that kind of causes the blood vessels in the brain to leak, stroke clinicians had to pay close attention, because what do we use to treat these patients? Of course, when they come in, clot busting drugs. And so very quickly people began to realize this might be a problem. And in fact, one patient in one of the clinical trials for Alzheimer's disease who got the new medication for Alzheimer's disease ended up having a stroke, was taken straight to the hospital, had an ischemic stroke, meaning stroke due to blockage, not bleeding. The Alzheimer's drug didn't cause bleeding. They had a stroke due to blockage. As we've discussed in the past, that's called an ischemic stroke. They were appropriately treated with TPA because they came in within 4.5 hours. They were treated, and within something less than an hour, had died. And the CAT scan showed multiple huge hemorrhages in their brain. Within 1 hour, they had died. Now, that is only one case. But of course, it only takes one case because we don't have enough experience yet treating patients with clot-busting drugs who are also being treated for Alzheimer's disease with one of these new medications. We don't have the years that have gone by and the experience to say, is it possible there are some patients who are on these drugs and it's safe to treat them? Is there something different about them? Is there something different about other patients on the Alzheimer's drugs that will make them more susceptible to bleeding if we treat them? We don't know. And we won't know until we get more experience. But for the time being, from national guidelines, from the American Heart Association, from our own guidelines that we've drawn up in our Northwell Health institution and our stroke division, we have basically said, if you are being treated for Alzheimer's disease, you should not be treated with TPA or tenecteplase, the two clot-busting drugs that are used widely, because we think that would expose you to a huge risk. So right now, while people being treated with Alzheimer's drugs, it's kind of a small number still. Let's face it, it's a new drug. It's just come on the market fairly recently, but we know that that's going to expand tremendously over time. And there's going to be some risk-benefit decisions to make. Maybe even when you decide, well, we think this person is predisposed to having a stroke because they have X, Y, or Z condition, maybe a lot of atherosclerosis of the arteries or something else. Say, well, the treatment for Alzheimer's disease works, but it's not a miracle cure. It just slows down the disease a little bit. We think this person is very predisposed to stroke. Maybe we'll hold off on the Alzheimer's drug so that if they have their stroke, they can come in and get treated with TPA or tenecteplase, the clot-busting drugs. That's a tough decision. Or it may be, look, we're going to take our chances. Anybody can have a stroke, but Alzheimer's is also a devastating disease. They've got early signs of Alzheimer's. Let's just say we want to protect them as best we can from Alzheimer's disease and preserve their cognitive function and hope, treat them appropriately with whatever we can treat them with to prevent strokes, and hope we never face that situation where they would be eligible for TPA or tenecteplase, but now they can't get it. These are very, very tough choices. And to bring in a probably even more common example, in the past, we've talked about people with a certain heart condition called atrial fibrillation. And that's an irregular heart rate that predisposes to blood clots forming in the heart, breaking off, traveling up to the brain, blocking off the blood supply, causing a stroke. And so those people, as you know, need kind of most of the time lifelong, not clot-busting drugs like TPA. They need so-called anticoagulants, what most people would refer to as blood thinners. Blood thinners, sort of the common name for it, but the technical term, anticoagulation, used to be Coumadin, and everybody was on Coumadin, and now Coumadin has been replaced by and large with the newer blood thinning type of drugs, anticoagulants. You'll be familiar with them, Eliquis, Xarelto. Those are the two most common, and there are probably millions of people now on these anticoagulants. Guess what? As far as we can tell from the clinical trials of Alzheimer's disease treatment, if they have to be anticoagulated, meaning on blood thinners, because, for example, they have atrial fibrillation, it's too dangerous. And they have a much higher risk of bleeding in the brain if they are on both medications, a blood thinning drug like Eliquis, just as an example, and they're being treated for their Alzheimer's disease. They have something like at least 5 times the risk of having a brain bleed compared to someone just on the anticoagulant, just on the blood thinner, but not on the Alzheimer's medication. So the other decision, and again, now we came up with these guidelines ourselves at Northwell, but in fact, recent statements from the American Heart Association have been the same, that if you require anticoagulation for atrial fibrillation, that's just an example because it's so common, but there are other conditions that require blood thinning medication. If you require anticoagulation, you should not get treatment for your Alzheimer's disease. So you can see this is very, very difficult. Just to answer some questions that I can sort of anticipate in people's minds, it looks as if aspirin is completely safe with the Alzheimer's treatments, and aspirin, of course, so widely used for heart disease, for stroke, and other conditions. So it looks as if aspirin is safe. So if you take aspirin for stroke prevention, heart attack prevention, or if you've had a heart attack or a stroke in the past, fine. You can still be treated with the Alzheimer's medication. And some people are on dual gentle blood thinners, double, like aspirin and Plavix. Many people know Plavix. Now it's generic, called clopidogrel. Many people with heart disease and others are also on Plavix or clopidogrel, same thing. Most likely, while the risk of bleeding on aspirin and Plavix together will go up if you're treated with the Alzheimer's medications, it's just a slight increase. And probably the benefits outweigh the risks. In other words, it's safe and more beneficial. You can remain even on aspirin and Plavix. Say if you have a stent in your heart, you're often on both. But the statistics say that it's safe enough and you can be treated for Alzheimer's with the Alzheimer's drug as well. You can see how complicated this has become in a very short period of time, because we never had to think about what anybody was on for their Alzheimer's disease, that's for sure. In fact, we hardly ever had to think about what anybody's on when they come in for TPA, for example, other than, well, are they on a blood thinner to begin with? Okay, you got to be careful. Make sure certain that certain factors, like they're on a blood thinner, but their blood isn't too thin and that kind of thing, you can treat them or you cannot treat them. Yes, we've always taken that into account. But the Alzheimer's picture has just kind of exploded the world of stroke. And remember, it's the same population of people, somewhat on the older side, who are affected by stroke as who are affected by Alzheimer's disease. They overlap to a very large degree, that population of people. So let me tell you, we have our work cut out for us. And we've been working very, very hard on making sure we can help the maximum number of people and not hurt anyone. And for better or for worse, that's going to mean excluding some people being treated for Alzheimer's disease from treatment, for example, with TPA or tenecteplase, the clot-busting drugs, because we have to ensure safety, and that's the trade-off. And it's been very tough. And it's been a team effort, stroke neurologists and Alzheimer's specialists working hand in hand, which we've never really had to do before because we never had too much to do with each other. We like each other and we respect each other, but we've never had to work together in this sense because we needed their knowledge of Alzheimer's disease and all the side effects of the new drugs for Alzheimer's. They needed our knowledge of stroke. So we worked very closely together with our colleagues in dementia and Alzheimer's disease to put together protocols, basically guidelines. Who can we treat? Who can we not treat for stroke prevention, for acute stroke, meaning as soon as they come in with their stroke? When is it safe? When is it not safe? It's a whole new world, and it's going to expand as more and more people are treated for their Alzheimer's. And we can only hope that as the time marches on, there will be new treatments for Alzheimer's without these risks of bleeding in the brain. And I'm looking forward to that day. But right now, the reality is we are stuck with this situation and we are doing our best to maximize treatment and minimize harm.
Well, thank you. And actually, you answered my question that I was going to throw out at you about the blood thinners versus the, what would happen with that. Just on a personal, I take Plavix because I had a stroke a number of years ago. If I hopefully not had another stroke, would that present a problem with the TPA or the tenecteplase?
Being on Plavix?
Yeah.
None whatsoever, Ginny. And right from the very beginning of TPA, approved in study finished in 1995, FDA approved in 1996, one of the fastest FDA approvals for any drug in the history of the FDA, because it was the first proven treatment for stroke. And basically, people could be taking aspirin, could be taking Plavix, and even taking both. And we've been treating those patients consistently over decades now. And once more, can you say that it's risk-free? No, nothing is risk-free except in, la la land. Unfortunately, we live in the real world, and most of our powerful treatments have risks. But what we look for always is, do the benefits outweigh the risks? And if the benefits outweigh the risks, then we can do it. And I don't mean the benefits outweighing the risks by a tiny amount. The benefits have to outweigh the risks by a fairly large amount to say, okay, yes, this is valid, and this is a treatment we should be using, and we do. So Plavix, absolutely no problem.
Thank you so much, Dr. Libman. Again, we hope we'll have you back for another segment in a little bit, but this is all new and very, very valuable information. Thank you again.
My